We are live, Jubin. We can go.
I'll unmute everyone, sir.
No.
Good evening. I'm Rajlakshmi. I'm using Vasanta's computer.
Okay. All right.
Welcome. So, Dr. Jubin, let's start.
I think he has muted us, all of us. I think he's
Yeah.
Pinto, can we start?
Yes, sir. We are live.
Will I start?
Yep.
Welcome to the second edition of the Endocrine Society of India's nursing webinars. And I think today we have a very interesting topic of osteoporosis, and it's World Osteoporosis Day. And on behalf of the President of the Endocrine Society, and welcome you all for this webinar, I now ask the President of the Endocrine Society, Dr. Sanjay Kalra, to start the session.
Thank you, Professor Jubin. Good evening, good day to all friends gathered here from across the world. The Endocrine Society of India has been working hard to improve awareness about endocrine diseases. When we look at the mission statement of some of the international endocrine societies, we see that they talk about optimizing health in patients of endocrine disease. But at the Endocrine Society of India, what we feel is that it is not only enough just to manage people with endocrine disease, such as osteoporosis, for example. We also have to prevent endocrine disease. So therefore, our vision, our mission becomes optimizing endocrine and metabolic health in every person on earth, whether they are children, whether they are adults or the elderly, whether they are men or women. In pursuit of this, we understand that endocrinologists alone may not be able to share the entire burden of this aim that we have. And we need help from all sources. One of the strongest soldiers that we have in our fight to optimize endocrine and metabolic disease is the endocrine nurses, our nursing fraternity. Understanding this, we have started a series of webinars on endocrine nursing. This is spearheaded by Professor Jubin Jacob from CMC Ludhiana and Professor Suresh Sharma from All India Institute Rishikesh. Last month we had a webinar on growth hormone, and today we'll be discussing osteoporosis. Allow me to mention that the people who are gathered here, Professor S.K. Singh sir, past president of the Endocrine Society of India, Professor Thomas Paul from CMC Vellore, Professor Jubin Jacob from CMC Ludhiana, Professor Sameer Agarwal from Rohtak. This means that the entire medical fraternity actually feels that endocrine nursing is important. We have with us Professor Suresh Sharma, Dr. Vasanta. This shows that endocrine nurses also feel that this is important. And we have with us people from allied specialties, from physiotherapy, Dr. O.P. Singh, from PMR, physical medical rehabilitation, Professor Iyer. We'll introduce them one by one throughout the next 1 hour. But what this Starcast shows is that all of us are united. All of us understand that what we are doing is important. With this, let me hand back to Dr. Jubin Jacob. But before that, sincere thanks to Professor Thomas Paul and Professor S.K. Singh sir for sparing time to be with us. Dr. S.K. Singh is Professor in Head at the prestigious IMS BHU in Varanasi, India. And Professor Thomas Paul is Professor at CMC Vellore in India. He heads the Bone and Mineral Metabolism Unit of this department. So Dr. Jubin, back to you.
Thank you. Dr. Singh, I'll hand over to you to give us a little about the background of what you think is the role of nurses in the management of osteoporosis.
Thank you, Dr. Jacob, and thanks to Dr. Sanjay Kalra for having this program on World Osteoporosis Day on 20th of October. The WHO has started celebrating this World Osteoporosis Day since 1999, and now it's 21 years. You can understand the importance of osteoporosis. Osteoporosis is a silent killer, a silent disease which goes unnoticed for years and is quite common in elderly, particularly people above age of 50, is more common in women after menopause. And now with the advancement, the lifespan increasing, more number of people will have osteoporosis challenge and problem in their life. The problem is multifactorial. We all know that is multiple factors are there which are responsible for achieving our peak bone mass, and that decides how much strong bone we have and uh, mm, how much this is needed to be strengthened so that we do not have the fracture problem and we prevent osteoporosis. So it has got two important components. One is osteoporosis itself, and that give rise to risk to fragility fracture. Now there are two things. You prevent osteoporosis at one hand, but at same time, if those who are having it, you prevent fracture. So fracture prevention is another important aspect of those having very high risk or those having severe osteoporosis. Now you can understand the osteoporosis can be treated. We have medicines for osteoporosis, but same time prevention would be better than cure, that we all understand that analogy. So prevention is always better for osteoporosis, but those who are having osteoporosis will have chance of having fragility fracture. Now, the role of the primary health care physicians, the role of primary health care worker is to educate people how to prevent fracture and also how to prevent development of osteoporosis in the risk group. So the doctor cannot interact or cannot have chance to interact with each and everyone who have high risk, and therefore the knowledge can be dissipated through nursing staff, knowledge can be dissipated through the other physiotherapists, to all those who are involved in patient's care. So this is very important that we educate people to love their bones and give this message through nursing who may be involved in endocrine services, nursing who may be involved in the orthopedics department, nurses who are also looking after the physiotherapy component, rehabilitation, and also the nurses who are looking after the elderly homes. All need to know, need to understand that this is one disease which can be prevented. And even if people are having disease, they can live better with the disease in them by preventing the fall and the fracture. So that is the good idea of educating, and I'm sure the intention of educating nursing staff and the all, as I said, all those healthcare workers is very effective way of going ahead and achieving our mission, our goal. That's the my understanding. So with this, I think we'll share the information, and we have the galaxy of the experts in the area, and also those who are heading the nursing component of health care providers. So over to the organizing committee.
Yeah. And Dr. Thomas, you want to introduce our speaker and the panelists for the evening?
Yeah, it is indeed my privilege. Thank you, Dr. Sanjay, President of Endocrine Society, for this opportunity. Thank you, Dr. Jubin, and my senior colleague, Professor S.K. Singh, for this opportunity. And I would like to introduce the speaker first, then for panelists for this important session. Today's speaker is Professor Rajalakshmi Hariharan Iyer, and she is Professor of Physical Medicine and Rehabilitation and Professor and Head Department of Medical Humanities, All India Institute of Medical Science, Rishikesh. And she's got a very excellent CV, starting from our MBBS days from Bombay University, then DNB from PMR, Chennai, and also she has extensive teaching experience. Especially she had a brief period in Christian Medical College, Vellore, as well as she had a long teaching experience in St. John's Medical College. Currently, she's professor of PMR, AIMS Rishikesh. And she has got additional qualification. I think physical activity is an important aspect. As a speaker, she's a good Bharatanatyam dancer. So that is what the CV says. That's an excellent. So it's a very apt, she's an apt person to give this talk. And I also, at this juncture, I want to introduce the panelists, Professor Suresh K. Sharma, Dean of Nursing, AIMS Rishikesh, and Professor Dr. O.P. Singh, Associate Professor, Occupational Therapy, BHU, and Dr. Samir Agarwal, Senior Endocrinologist from Apex Hospital, Rohtak, and Dr. Vasanta Kalyani, Associate Professor, All India College of Nursing, All India Institute Medical Science, Rishikesh. And it's wonderful. We have a wonderful team, as Professor S.K. Singh put it. Thank you, Dr. Jubin. Over to you.
So I'll invite Dr. Iyer to start her presentation. She can start sharing her screen as well. I'll request everyone else to mute their microphones.
Good evening. Can everyone hear me?
Yes.
Yes.
All right. At the outset, thank you for inviting me. I speak from my experience of having worked in St. John's Medical College very closely with geriatrics division. And she was my neighbor, and she was a colleague, and she was happy to have rehabilitation, and I was happy to treat the old people. So that's where my talk comes from. Greetings from sorry, right. So that's how
So
the
full
morning
screen,
looks
please.
like in Rishikesh. Sorry, can you
Click on enable editing at the top on the yellow bar. You see a white button.
Yes.
Okay, perfect. Now
Is that fine?
Yeah, on the bottom you will find where the plus minus is there. There is an icon for you to do full screen.
Right. Yeah, is that better?
This one.
This one? That's slideshow.
Yeah. Perfect. Please.
Is that better? Yes.
Yes.
Okay. Sorry. So that's what a typical winter morning looks like in Rishikesh. And how do I just keep clicking? Okay. And that's another view of the Ganga, which is right opposite the AIMS building in Rishikesh. A road divides us from the Ganga. So we are indeed blessed. Okay, so before I go to this, I would like to first of all say that this is to express my deep appreciation and admiration for all the nurses I have dealt with in my life. And what I really, really admire about them is the discipline. It's almost like the army, no questions asked. They know you're utterly wrong, but they will still do what you want them to do. And the grace with which they handle you people, I shouldn't say they. I hope all of you are listening. The grace with which you people handle interns and medical students. Like I said, most of the time you're probably doing wrong things, but you turn the tide so beautifully. So appreciation and a very, very heartfelt thank you. All right, now let's go on. To give you an overview of my talk, it's going to be, I think, practical what I have gleaned from working with old people in St. John's. So it might be less academic and sort of more practical. Please bear with me. We all know of old people who fall, and it is scary to think that every fourth person is very, very likely to fall. And this study was actually done in the community. It was a large sample done in Bombay, and the prevalence there was about 1 in 4, 25%. And most of them occurred indoors. Most of them had slipped. And it's scary to see that, at least 2/3 had sustained injuries. I would think morbidity would be close to 100 because though all of them may not have fractures, they might have abrasions. And what most of them have is fear of the next fall. And that, I think, adds tremendously to morbidity. So why are they such a problem? This is often because old people are often on the brink. They're finely balanced between health and illness, and especially the frail, who are in the twilight zone. So if once they fall, I'm sorry to say that treatment often adds to the problem. They might require prolonged periods of immobilization. And like I said, they are afraid of falls, and the family begins to be afraid of falling, and they restrict activity. And that is how the downhill course begins. So though hips may be replaced, the course generally is downhill unless we are very, very, very careful and motivated. So why do people fall? What are the risk factors? I put it as a question, thinking that maybe the people who are listening could use their chat boxes and come up with the answers that come to their minds, the common ones that come to mind. Would that be an option? Or should we go on? Can the listeners use their chat boxes to come up with why older people fall? Would that be an option?
Yeah, I mean, but they can only ask questions and we can get the answers only later because it is live streamed right now.
Right. They cannot use their chat boxes?
They can, but we can only get those questions later.
All right, fine. So can I wait for then 30 seconds while people type in their answers?
We may not be able to get it immediately. So I think we'll just...
Okay. So, all right, then let me put this question to you to set the tone for the evening. Why do older people fall? Apart from all the obvious reasons that we can come up with, some of the commoner reasons that we need to keep in mind are these. Often it is medications that cause people to fall, the side effects of the medications. Sometimes, my father included, they continue to think they are young, and they will climb stools to dust, and they will climb ladders to pluck flowers. So high-risk behavior in the older people is something that we need to keep in mind. Now, the very common cause would be unsafe footwear and inappropriate clothing. I have a slide on that. We'll come to that later. And when they are visiting children, or when they travel and they are unfamiliar with the environment, they might bump into things or trip and fall. So these are some things that we need to keep in mind, which are very common, apart from all the really common ones that we have. Okay. So one advantage of talking is that one starts reading. So some of the interesting impairments that I came across in old people, causing this is across the spectrum, and this is irrespective of the medical diagnosis. So often as we age, the postural reflexes seem to be blunted. So postural sway increases. This is a well-known fact. So sway meaning that the center of gravity, which is somewhere around the S2 at the lower end of the spine, travels more than it did when we were young. So this tends to increase the risk of falls, especially if the base of support is small. The other very interesting thing that happens, and I think I can vouch for it, is a reduced step height. It is known that step length reduces and the width increases, but step height or the clearance of the foot or the dorsiflexion of the ankle is very, very commonly affected, because the tibialis anterior is a muscle that is very prone for weakness. And one way that we can check the quality of our tibialis anterior is to squat. So in the olden days, squatting was a part of our daily activities, and nowadays it is not. So if one is able to squat comfortably, then you're all right. And the weakness of the tibialis posterior is largely responsible for this reduction in the step height or the clearance. And muscle-wise, if we see that, see the distribution, the knees are affected, and like I said, the ankle dorsiflexors seem to be markedly affected. Fear of falling is something that is unfortunately built into the system. If we stumble also, we are scared. If we are osteoporotic, a stumble is enough to create damage. So fear of falling, it is so vivid that it is now called FOF and recognized as FOF, fear of falling. This is something which is very interesting, something called motor estimation error. We often think that we can do far more than we actually can. So when we are tested this often, for example, the functional reach, there is a test called the functional reach, where since you can see me, I can show you. I don't have a video. So one reaches across the near a wall to see how far forward they can actually bend without stumbling. So that's called the functional forward reach, which is a very, very sensitive test for the motor estimation error, which means that we estimate in our heads more than we can actually do. And that gap often leads to a fall. We often lose contrast in our visual acuity as we age, and especially in low light, this can be disastrous, and our attention can be less and less and less divided. Even women who are otherwise very, very good with multitasking, but as we age, we lose the ability to process multiple sensory input with a motor activity. So that can very often lead to falls also. So they need to either walk or they need to do whatever else it is that they are doing. And as the old often have huge problems with this. Okay, so those were interesting things that happen to all of us as we age, irrespective of multimorbidities. Coming to falls assessment now. How do we assess if a person is at risk to fall? Unfortunately, there is no standardized tool that all of us can use across the board. Also, OPDs are very busy. There is a mix of people that most of us see. Very few of us see only old people. So the OPD time that we get is very, very little. So are there tests that we can do just like that and pick up that this person is likely to fall? So these are some tests that can be done easily, timed up and go. I have a video at the end of this presentation, so we could talk as we see that video. Basically, a person gets up from a chair, walks for 3 meters, turns, comes back, sits back on the chair. And the observer looks at the difficulties or the ease with which the tug is done, timed up and go is done. There is a time cutoff. So a normal person would do it within 10 seconds. And so if there is a 15-second or more then there is a risk, falls risk becomes quite high. Sometimes it goes as much as over 20 seconds. 20 to 30 seconds is a big problem.
Session is on.
There is also a test to look at the endurance. Time the walk for 6 to 4, 6, 8 minutes and see what distance is covered.
Session चालू है, घर पे चालू
See
हो
if a person can stand on a single limb with support, with a support handy, with a chair nearby, so that they do not fall. Usually we should be easily able to stand for half a minute. So there are cutoffs for these tests, which are very, very easily available. So this is a simple test that can be done in the OPD. Tandem walking is another simple test that can be done in the OPD. And looking at the time taken for each of these, we could make a rough estimate of the tendency of the person to fall.
You speak because
they cannot hear. Okay. So what the person was doing. So what the person was doing was what I just explained to you. A chair has the armrest, but ideally armrests are not used. The person gets up, walks, turns, comes back, sits down. So that would be the timed up and go, which is a very, very validated test. So this can be easily used in the OPD. So apart from those single tests that can be used in the OPD, there are some clusters of tests that can be used. The test that we used, or the geriatrician in St. John's used, was the FRAT. So FRAT is the false risk assessment tool. And it is a very simple 4-item false risk. It's a screening tool. So that can be used in the OPD as well. It is easily available, so can be looked at and downloaded. And the good thing about it is that it has a checklist also for risk factors. This is another one that the BOOMER, or the balance outcome measure, is something it's a cluster of 4 tests, most of which I showed you in the previous slide. So this could be used again to assess false risk. This is the FRAT checklist. This is what it looks like. So recent falls, which is the biggest risk factor for falling, just like a previous stroke is the biggest risk factor for another stroke. Similarly, recent fall, a fall in the past, is the biggest risk factor for another fall. So recent falls, medications, which I just told you about, psychological, which nurses are at special, a very advantaged position to pick up, and cognitive status. So a combination of these 4. Cognitive status, actually the FRAT comes with its own cognitive test, the AMTS, but the AMTS has some questions that may not be culturally relevant. So though FRAT has said ideally not to change the format, but what we used, it was the mini cog. And there are also studies that say that NMSE correlate to false risk. So 24, a score of 24 on the MMSE out of 30, very, very high chances of falling, and a score of 28 out of 30 in the MMSE increases the false risk by 3 times. So, but what we used was the mini cog. If you go down, there is also the sorry about that. Yes, sorry. Thank you. So if you go down the checklist, you will see that there are risk factors for falling. And these are the commonest ones, which I hope you have thought of in your, and put in the chat boxes also. So vision, mobility, transfers, behaviors, activities of daily living, environment, nutrition, continence, and space for others. So this is a checklist that can easily be done. And the good thing about all these tests are, this is the MMSE I was telling you about, 24, which also I believe equates to dementia, increased falls risk, 28, which is actually a high score, because the one that you -7 from 100, I am not sure I will be able to do that. 28 to me is a high score, but this is proven that increases falls risk 3 times. Okay, so FRAT was one test that we used. This is another checklist that is from a study that is actually ongoing now, and this is called the STRIDE, Strategy to Reduce Injuries and Developing Confidence in Elders. So this was this is being done at this initiative was started at the National Institute of Aging in 2014, and the numbers are very impressive. So 5,000 plus elderly, 65 and above, I think, 70 and above, are being followed up for 2.2 years, and it's ongoing. And this checklist is from there. And the good thing about this checklist is that they're all modifiable. So they are looking at these 8 modifiable risk factors, and they are trying to correlate. The results should be out now. 2020, I think, is what they've said. So this checklist, because it is modifiable, it will tell us soon, hopefully, how much weightage each of these carry for falls risk. So let's go by this checklist. Medications and postural hypotension are very, very closely related. Footwear, I have a slide I will come to. Vision, we spoke about. Vitamin D, home and work environment, strength, gait, balance impairments, which can actually be reversed with exercises. And like Dr. Thomas Paul said, the primary care physician, I think, needs to be involved. And if they follow up with the primary care physician, I think that is a very, very profitable relationship all around. So these are the 8 risk factors they are looking at. Protocols, meaning are protocols and algorithms used in trying to assess risk fall in the elderly. So problems with medication, we've this concept of polypharmacy. The person goes to an orthopedic surgeon for knee pain, a neurologist for neck pain, and multiple other specialists, each of whom feels obliged to add medications of their own. So if you have 3 into 4, minimum would be 12 medications, and that is polypharmacy, without looking at the interactions or what the other person has given before. So polypharmacy is a major, major problem when you are dealing with old people. They are not just people who are old, they are people whose physiologies are completely different. They have multiple comorbidities, and the medications behave in a completely different way in old people. So polypharmacy is a major problem. And like I said, often thoughtlessly prescribed. I might have done it. I'm guilty, I'm sure. You just want to satisfy the patient, or you want to get on with the next person, and you prescribe 2 medications just so that they will leave. So that is how thoughtless it can be. And I am guilty, so I can tell you this. And there is no one person. I wish the primary care physician would take on this onus of overview of the medication list. So one of the happiest things to do on rounds when you're with old people is to cut down the medications. So these are the problems with the medications that we often prescribe. They lead to sedation and confusion, and very often orthostatic hypotension, all of which can independently cause falls. And as you can see, I will go quickly on the slide, the odds ratio for these medications can be significant. So medications are a problem. Not to say that not to use them, but I think one needs to be sensible in choosing the kind of medication that is needed. So these can be avoided. Over the counter, which all of us give our parents, can absolutely be avoided because many of them have anticholinergics and antihistamines, which can sedate and make the person groggy. Amitriptyline is again a medication that's used for neuropathic pain very, very commonly. It can be additive and it can again add to confusion and grogginess, apart from the anticholinergic problems. Sedatives, 2 days you don't sleep and you are prescribed a sedative. So sedatives in the old behave very differently as compared to young people. So in children and in the elderly, the sedatives we need to be very careful about giving them sedatives. Antihypertensives that do not cause orthostatic hypotension, we need to be very careful that we choose wisely. And drugs with anti-diabetics that are prone to cause hypoglycemia, like glibenclamide, or even insulin, we need to be very careful when the person is on insulin. And drugs that can be avoided should be avoided. Beer's criteria is a list that actually talks about inappropriate medication use in the older adults, and I think can be referred to very, very easily available. Okay, we talked about inappropriate footwear. So the question mark is to choose the most appropriate footwear among these four. And since I was thinking this is another chat box question, but it's always wiser to wear footwear that are anchored at the ankles. So sandals are people, though they have to bend and fasten it and unfasten it, it's much, much safer in the long run. One can trip over footwear like this. This does not give enough support to the toes to hold on to the footwear. And these two can actually lead to clawing in diabetes. So slippers, not to be used as far as possible. Sandals are a good option as far as footwear is concerned. Role of vitamin D supplementation, I think there is no doubt. The effect size is, of course, very different in different studies. But since this is a modifiable risk factor, and because vitamin D is so widely used physiologically, I think it makes sense to make sure that it is at least above 50, and it is easily done. The dose that is now commonly used is weekly. So the dose in this study said that it needs to be over 700 units per day. But the commonly used method now is per week, 60,000 units per week orally. So that should be okay. Okay, I would like to spend a little time on exercise and activity now, which is a modifiable risk factor and important because low physical activity, frailty are very, very common in the old. So low physical activity leading to sedentary lifestyles almost. So very, very important to include exercise in the lifestyle, and more important than exercise, activity in the lifestyle. So what kind of exercise? Studies have very, very clearly shown that traditional exercises like happening in physiotherapy are of limited value. So because they deal with one modality, like for example, strengthening. So that may not be enough. What it needs to be is multi-pronged, meaning that I think the next slide will show you what I mean, meaning that it needs to work on strength, on flexibility, on balance. So multiple modalities, and 2 hours a week, that's a very, very encouraging finding. That 2 hours a week, I think, is not tough, but it must be at least this much. And ongoing exercise is necessary. This I think, is an uphill thing to benefit and a downhill thing to lose the benefits. So unfortunately, ongoing exercise is necessary, and the effects are rapidly lost when the exercise is stopped. So that is the reason that it needs to become a lifestyle activity rather than staying at the exercise. So this is what I meant by multi-pronged. It is not just strengthening of muscles that we are looking at, but we also need to look at flexibility, at balance, proprioception. This is something that most of us stop doing, which is to engage the core even while walking. And like I said, practice with divided attention tasks, at least dual, if not multitasking, not having to look on the path all the time while walking. And something that improves, something that's happy, and something that improves confidence in the person, so that the person will continue doing it and does not need a person with a stick behind to make them do it. So taking off fear of fall is, I think, half the battle won then. And this is something which is always in the background of a person who is elderly. Mood changes, could be a low mood, but in the background of the mood, if all these are done, I think that is very, very useful. And I think it does us very well to keep an eye on the mood. So these are some handouts that can be given. These are basic exercises that can be given, placed as printouts and given as handouts. So tandem walking, marching in place, holding on to a chair, and balance exercises. There is a video with balance exercises, so I will skip through these. This is again something that we need to do. This improves proprioception, and which is very easily doable at home also. So the grandchild could say, come to 1, or come to 7. And so placement of the foot would be a very useful thing rather than just going on with strengthening exercises. Strengthening we use as a very, very general term, but I think we need to focus on what really is the problem. And these are the problems as we age. We forget about our core muscles, and they're actually easy to get back to and learn to engage. Ankle dorsiflexors we've talked about, so one often trips on the toes. We've talked about knee flexors, extensors, quadriceps, and upper limb muscles are one group that is often forgotten. So if we make it part of our activities of daily living and use upper limb muscles, that would be a very good idea. This is a video which talks about the importance of stepping. So obstacles on the way need to be gone over. So it would be a good idea to place obstacles like this. Did you see that lurch that happened when she started? So exercises like these are very, very useful. And as you can see, it needs to be something like a play activity, and it needs to be something like a group activity. It can get very boring doing these just by yourself. Doing the same thing, sidestepping, you can increase the complexity as you go along. This is, I think, something that is very well known, figure of 8. This is an increased complexity with the figure of 8, doing it backwards. Okay. Once the person falls and has had a hip replacement surgery, this is the key to getting them back on their feet on post-op day 2. So they can start with simple activities and come up to sitting, maybe on the 2nd day, standing by the bedside on the 3rd day, walking around the bed, with a walker, partial weight bearing, and progress on to strengthening and balance exercises. But these are okay. The physiotherapist might look after these. But this is what we need to push for. Early mobilization post hip replacement surgery. And this is again something to remember, because these tend to go on, because pain tends to go on because the person is in a low mood post-op. So often this is a vicious cycle, and once early mobilization starts, activities of daily living start, it might be easier to taper and stop the pain medications. This deals with the environment. So our bathrooms in the olden days were very good bathrooms. They were small, not enough place to fall. We didn't have fancy tiles. We squatted. But since this is a reality now, raising the level of the closet with grab bars on the sides, grab bars in the bathroom, good lighting, one level in the house and in the bathroom, and of course, non-slip tiles. These are all things to think about, because they say, as they say, it's true that the bathroom is the most dangerous room in the house as one ages. Hip protectors, I have put up this slide. I have never seen one, and I have never seen one used. I spoke to my orthopedic surgeon yesterday, and she has not seen one being used either. But I think this is a very reductionist approach to protecting the trochanters when you fall, or the neck of the femur. So these are hip protectors that are available apparently and can be used if one feels like. But I do not have experience with this. And last but not the least, I think we need to remember that there is nothing that better fits into the ICF model than falls, because each of these are completely important in contributing to fall and to the prevention of falls. So before I leave, some thoughts that I think are important. These are not studied, they are not validated, but one of the most important things I think that can be avoided is getting up at night to empty the bladder. And this is often a habit. So the habit can be changed with practice, and fluid restriction after 6 p.m., empty the bladder before going to bed. These are good practices to follow and can be achieved really. And if not, I have personally used condom catheters. I've had people come back and say that they were very useful in people who will not listen. We've spoken about this. Fear of falling is really often worse than the falling itself. Outdoor activity is far more important. It just will not do to say that I'm walking 10 rounds inside the house or 2 rounds on the terrace, because outdoors, the challenge is far more, and it's a given. Terrain is uneven, there is traffic coming, there are friends you meet who are talking. So all this contributes to improving agility and balance. No bed rest for old people as far as possible, please. So avoided if possible completely. Sleep is often underestimated, and it's important to practice sleep hygiene, not sleep during the daytime, do enough physical activity to earn your sleep at night, and often light and dark, exposure to light and exposure to dark, are very important to reset or to set circadian rhythms. These are often overlooked small points that actually give huge benefits. Group therapy, like I said, can be extremely satisfying for all around, because it saves the therapist time and saves the nurse time. The people in the group are happy. So it's a win-win. Group therapy is very highly recommended. And good old age has to be earned. It does not come sitting on your backside and praying. So it comes from a lifetime of living well. Thank you.
Thank you. I think Dr. Singh and Dr. Thomas.
Yeah.
I think before we get the questions, I think Mintu will give us the questions from the audience. We want to start the discussion.
Yeah. It was Dr. Professor Singh. Professor Singh first.
Yeah, I think I had a small query regarding home safety, and that has been very well answered. Dr. Ralakshmi told about home safety. We have to remodify the toilets as we advance in our age. We have to keep provisions that if you have a working toilet, which is quite nominally, that can be minimized by provisions of these supportive rods and modifying little bit of the toilet materials. I think that point has been taken care of by Dr. Rajalakshmi. So over to Dr. Thomas.
Yeah, and also I think one important point from vitamin D perspective, and they all give temporary vitamin D treatment, but the diet is not enough to cover in Indian setting. So I make a strong statement on behalf of Indian society: when you give cholecalciferol, it is still death. So somebody above 60 years come, we tell next 40 years you have to take. There's nothing like vitamin D intoxication. Oral, I'll talk about. So that also you covered very nicely. I appreciate that that was the thing. And some of the things were very important. Basically, as physicians, we forget to do false assessment. Thank you very much for that.
I had a question for Dr. Iyer. As part of your practice in Bangalore, would a home visit also be part of the assessment of a patient who is likely to fall? Because
please finish. Sorry.
Because I would think that the home will give you a lot more information than what you can get in the clinic, at least with regards to the risk of the patient falling.
Absolutely. I think home visits, I have gone on a few home visits to see spinal cord injured, and I can absolutely vouch for it that it completely changes the perspective. Yes, I think that's a very, very important point. And if we had people who could make home visits, that would be a wonderful idea. In our rehab team, the occupational therapist does it, but I suppose anybody could be trained to do it. Yes, I agree with you.
Yeah, I think in most Western countries, it's usually a nurse, the community nurse, who does the home visits and gives inputs to the patient and then gives back the input to the doctor that these are the risks and I think even occupational therapists in the hospital, if a patient is admitted, they do a whole set of assessments before they release the patient to their homes, including making themselves a cup of tea, climbing stairs, seeing how their stair assessment is. I think that is something that we really do not do, because most of the time we know that when we are sending off our old people, we are sending them off with their families, so we don't have to worry about them. But in Western societies, they're probably going to be staying alone. So we need to be very sure they can take care of themselves before we can discharge them from the hospital.
Can I ask one question to you? What is your, we do see lots of, as a endocrine and metabolic thing, diabetes is big way. After that, they have strokes, cerebrovascular accident. So they are also anterior circulation or posterior circulation. They are either hemiplegic or hemiparetic or ataxic. So they are at very high risk for fall. So what you advise in your clinical practice, because this group of people, I don't know what is the care they get at home, what is the advice. So what is your experience on that? The people with stroke.
All that we covered was actually, unfortunately, for the more or less well old. Once morbidities come in like this, I think we at Bangalore gave them a period of inpatient rehabilitation where the patient was assessed, taught, aids given, also family trained. But what tends to happen is that naturally their mobility tends to come down. And they are satisfied with only walking maybe from the bed to the bathroom and back. And for other things, if the home is wheelchair accessible, then they would really strongly suggest a wheelchair, especially for posterior circulation strokes. But I think it is a self-limiting condition when any of these other morbidities happen.
I will also put a, like, as a thing, Dr. Samir, what is your, this thing? You can.
I think, sir, we had a very nice presentation. Some of the things, like you told, are good learning for us also, because these things, from nursing point of view, we ignore. I think that one slide of hip protectors, I think patients of poliomyelitis, we have a lot of cases here in India still who are suffering from poliomyelitis. They have a unilateral osteoporosis, which is significant. And I think in these patients who have these low bone mineral density at the neck of the femur, these things are really helpful. In fact, these gadgets, we are not getting it routinely in India, but abroad, I feel we are definitely getting all these devices. After a hip fracture, also there are some devices to how to pick up the things and all these things. But from nursing point of view, I think it's very important that we focus on the factors which can improve the osteoporosis, interventions which we talked about in today's presentation. In fact, even in the acute phase of osteoporotic fracture, we advise patients how to lie down and what should be the knee flexion and intermittent, some local heat and back rubs, which can promote some muscle relaxation. And these tips which can improve the body mechanics, I think these are very important. And improving the bowel movements by advising these patients laxatives and all this nursing care, especially in acute osteoporotic fracture, there is a, I think, very important role of these nursing care. So had been a great learning today evening. Thank you.
Dr. Vasanta, I think I'll ask you this question. In your current, I'm sure you're involved in teaching nursing students, you're involved in guiding postgraduate students as well. In your current context, do you really concentrate on osteoporosis, fall prevention as part of your nursing curriculum? Do you emphasize on it, or it is something that, if required, they might acquire the skills later?
Thank you, sir. So we are emphasizing in the curriculum as a endocrinology nurses. We are producing, we are emphasizing from the assessment onwards. The students, they have started to doing the assessment. From there itself, we are emphasizing. So even a small height measurements, they have to emphasize back to the client, your height is this much. If the patient is a prone age group, we have to ask them whether the height is your previous height. And then if anything, you are having the change in that. If they have the history of previous fracture, then we have to correlate. So this a small first step, we are assessing them how much is their level of their osteoporosis chances, and then their calcium level, vitamin D levels. So it is beginning from the height and weight itself. So for the endocrine assessment, we are focusing totally, and then in the area where they are going, they are doing this same assessment, and then they are identifying osteoporosis patients. And then in orthopedic students, specialized students, they are having the special projects to identify the osteoporosis and then finding out their what are all the other activities to prevent the further problems, and then they can educate them in early part. that we are having in our curriculum, and then we are doing also. Every student is focused on that.
And Dr. Singh, do you think that if, like in a bone team that you have, the adding nurses, community nurses, especially going home, doing assessments at their home, do you think it will be a cost-effective, valid for our country? Because most Western countries, they have this. They have community nurses, they have nurses part of the osteoporosis team who go home, who do all these assessments on their own, who prescribe them the right kind of protective equipment or devices, assess them. But do you think in our country there would be a financial, economic this thing to promote or provide training for nurses to do this?
Yes, very rightly said that the nursing training and making them empowering them to give education to patients and their family members who have a risk of osteoporosis for prevention of fall. I think that's very, very important. Physicians or doctors can treat osteoporosis, can detect osteoporotic people having osteoporosis or high chance of fracture. But at the same time, to prevent fracture, fall and fracture, I think nursing staff had to come forward, and there should be a kind of arrangement made in most of the clinics, whether it is endocrine clinics, a bone clinic, or it is orthopedics, that they must have this team, including nursing staff, who can educate for prevention of fracture, at least at the institutional level. Of course, at community level, this would be very, very effective if we have, and it will be very cost effective also to have nursing staff going to community. In some of the places, in centers like in BHU also, we have a training program for nursing, and they are actually sent to community, and they are given information how to educate the people in community for prevention of most of the diseases. So that would be very cost effective, looking at the large number of people living in community in our country. This had been good in even in developed world where they do not have that much population. Still they are having it, because that becomes very convenient and very cost effective for people. They don't need to travel to cities and to the hospital for this kind of information that can be given. And as the fine nuances which was covered by Dr. Iyer, that many small things can be done. For example, that padding, I learned that this would be very effective. Many times I have seen people having fall from the chair and they fracture their hip. This kind of padding would be preventive. So I think nursing involvement will definitely magnify our effect or our attempt to prevent osteoporosis, and that has to be addressed. Every time in any of the nursing meeting, I always say that why don't we mobilize nurses to go to community by some mechanism which is not very effectively being utilized. So they can go and they can, yes, they can educate the people in community. Some of the members, some of the housewife can be trained, and they will look after the whole family. All those having a risk of fracture can also be taken care of by just educating the elderly females in the family. And nursing staff would be an asset, I guess. I understand. And if I'm given a chance to organize things, osteoporosis clinic or bone clinic, I will definitely take the help of these nursing. And I'm sure Dr. O.P. Singh will agree, because we have started PMR very recently, and they have been instrumental in making it a big department now. PMR department is functioning very well, and Dr. O.P. Singh will definitely highlight this aspect also. So there is a need to recognize that nursing staff involvement would be very cost effective in preventing fracture in osteoporotic population.
Dr. O.P. Singh, do you want to talk a little bit about using?
Yes, sir. Are you in a position to listen everybody? Are you able to listen, sir?
Yes, yes, we can hear you.
Okay. We had a very nice talk from Dr. Iyer. I just want to add up some of the things. Nearly she has covered everything, each and everything. Her emphasis more on the proprioceptions, because with the aging, there are changes in the proprioception acuity. That has to be emphasized more. Flexibility can be done in form of aerobics, yoga, and that is also essential. As far as the spinal osteoporosis is concerned, here we can add up back extension exercises. Generally, we add up back extension exercises whenever there is a compression, the osteogenesis occurs. So that is one of the factors which can be added up. As far as muscle strengthening are concerned, ma'am has already covered. She has told there is weakness in iblis anterior and posterior also. When we are using the ankle strategy, hip strategies are more important in balance parameters. So ankle, she has added up that obstacles, side turning, and so many things. So that is one of the protocol which has come later on. And if that emphasis is done, definitely there are changes in the person. So that can be added up. As far as respiratory conditions are concerned, one should emphasize on the respiratory uh, increase in the vital capacity. That is more essential. What I want to add up, she has told regarding the chappals, sandals. So whenever we are using sandals, there are chances of inversion, eversion more. So that can lead to the ankle twist. So it will be better if we can add up anklet in that condition. So these are the basic things which can be added up, and that will help us in more better programs of the osteoporosis. As far as prevention mechanism is concerned, home modification, it can be done. And home assessment, whenever a person goes to home and home assessment is done, he can increase the family atmosphere. Because when the family atmosphere is socialization increases, the person is confident in him or in her, and the small things which can create problems, that can be modified, which ma'am has already covered. So I don't think there is much to speak on it. I think that's more than sufficient. Just briefing on which I added up. The rest ma'am has already covered. And there is role of nursing staff everywhere. Definitely indoor patients. Whenever there is indoor patient, like we are discussing of the CVA patient, whenever there is a problem in this a person is having a stroke, what happens? We allow the person to go in the toilets and the person starts walking. There is a synergy pattern in the lower extremity, which a person have a stronger synergy, extensor synergy. So the leg becomes stronger, but the flexibility means extension is easy, but flexion is not possible. So we should emphasize on flexion attitude also. Once we increase the power in the flexors, then the correlation of both the group of muscles help in the proper ambulation. Even during the transfer, we should take emphasis on the we should hold from the step below the shoulder level so that there should not be any subluxation. There are chances of subluxation are always there. So with the osteoporosis, if there are more risks, we have to emphasize on these basic things. So that all I have to say. Thank you, sir.
I think I'll ask the last question to Professor Suresh, since he has a more wide view. Now, after hearing all this talk, and I think in India, we are getting more and more, I mean, most of our clinics are now using diabetic educator nurses, and we are using a lot of diabetic educators. I think almost a lot of the major centers have diabetic educators. So looking at that, should osteoporosis be, I mean, the diabetic educators are always there in endocrine clinics. Should they be part of orthopedic nursing, or should osteoporosis prevention and all this be part of the endocrine nursing, and diabetes educators should handle this? Because orthopedics, usually they have already had a fracture. And if you want to prevent that fracture, probably it has to start in the endocrine clinic when we are treating osteoporosis before they have had their fracture. So where do you think the priority should be?
Dr. Zubin, I think that in most of the tertiary care institutions in India, we need to begin the fall prevention clinics. And that could be the part of PMR department, or that could be part of geriatric department if department exists. And how we can do that is every person who is, either primary physicians or the endocrinologist or the orthopedicians, whoever takes care for any person who is in a risk of osteoporosis, they can have a quick small fall risk assessment tools, which could be indigenized, which could be comprehensive and smaller in size. And once the risk is assessed, these people must be referred to the fall risk assessment, the prevention clinics, which should be led by nurses, which happens in Western world with my experience traveling America and Europe. And what they can do, they can give a small instructions in form of a booklet that these are the changes you require at home. These are the changes you require into your lifestyle, be it exercise, diet, or drugs, or other things. So what we can do is we start a preventive strategy from hospital itself, and then they can be part of PMR department per se into the other tasks, so that the right utilization of human resources can take place. And I'll come down to community resource development. Now the government of India is coming up with the health and wellness centers. And in health and wellness center, the module is taught to the nurses, so they can take up the charge of CHOs, community health officers. I recommend, and after this webinar, I'm going to write a letter to ministry that in this module, the fall risk assessment and fall prevention home modifications must be incorporated within this module. And I'll shoot this letter tomorrow. This is my submission from where India to begin, and then we have a lot many things to do. Thank you.
I think at least we have something positive coming out of this webinar. So thank you, Dr. Iyer, for this, for highlighting what is possible. I think it's not just the drugs that are the treatment for osteoporosis. It's a complete care of the person, including assessment of falls and trying to prevent the falls. I think there, and I'm glad that the health and wellness clinics might be a very good way to get this into the community as well. So I think it's a very valid point. And with the kind of clinics that are coming up, I think a lot of them are coming up all over the country. So I think that is a very valid point. So I think we are now 15 minutes over our time. So I want to thank our chairpersons, Professor S.K. Singh, Professor Thomas Paul, our speaker for the day, and all the panelists for having an interactive session. I don't know whether Mintu is still there, but Mintu is the person who has handled our live streaming. And he's assured me, and he's not yet told me how many people were there for the session, but he'll probably tell us at the, I'll tell you in the email I sent later how many people were exactly there for this webinar. So thank you very much and good night. And hope you have a safe week.
Thank you.
Thank you. Good night.
Thank you.
Good night, everyone.
Good night, everyone.